Thank you very much for the invitation to this kind congress.
I understand what you say.
This subject is about a new nomogram to compensate the hyperopic shift in using the FCAT treatment with allegorical laser. It's not a clinical nomogram, it's a calculated nomogram. During the crystalline accommodation, there is myopia, Q factor negative, and spherical aberration negative. If we're studying the accommodation lens, the change is about the spherical aberration. It's quite sufficient amount of negative spherical aberration to read a book without glasses. The relationship is linear between the amount of accommodation and the negative spherical aberration. You can verify it in using an aberrometer with a young patient and with some myopic glasses to force the subject to accommodate and create a myopia and decrease the spherical aberration, and we verify the relationship between the myopia and the negative spherical aberration creation. The Presbylasic has to simulate into the cornea what the crystalline lens does in keeping emetropia. That's the challenge. We are using the wavelet Alligato 400 Hz IQ as velocity modulation. This laser is possible to modify Q factor asphericity from 0 to -1. Presbylasic with FCAT treatment. F is Q factor, CAT customized ablation treatment. In one step, it's a wonderful treatment because you can change in one step myopic and astigmatism and presbyopia, hyperopic and astigmatism, and presbyopia. But if the preoperative refraction is planar, for instance, with FCAT treatment, if you have a target Q value -1, it gives an hyperopic shift approximately +2. The question is how to avoid this hyperopic shift, whatever the preoperative ametropia is, to obtain always the emetropia for a good distant vision. What the wavelet Alligato does, if we're studying in a aberrometric treatment, aberrometric customized ablation treatment, we can see on the Zernike RMS polynomas, and if you put off the tilt, the high order aberration, you obtain a spherical treatment. For instance, for a myopia for -3, you have a look on the Zernike polynomas, and you can see for -3 diopters this corresponds to C4 Zernike polynomas plus 4.5 microns RMS. Then we can obtain a relationship, a linear relationship between the diopters of ametropia and the very precise microns C4 Zernike polynomia. We have such a new nomogram, very simple, because at first we do not consider the examination, the preoperative examination asphericity of the patient. We consider Q value is 0 in the examination, because an emetropic pseudophakic eye need +3 for reading whatever its preoperative asphericity Q value is. Second, to get a simple nomogram, and third, to avoid dispersion of the results due to the different preoperative Q value of different patients. And then, at the contrary, we fix the target Q factor target to -1 for the both eye, because an hyperopic treatment of +3 gives a naturally Q value -1 approximately for every patient. We do not want to use a monovision. As Dr. Genasia and Blondel have said before, the monovision is not a good solution because it gives not a good vision for every works, especially on computers of night mark driving. To get a very simple nomogram to avoid error, also of programmation on a multi-operator examer laser center. All the operator remain center, program pre-operatively asphericity 0 and post-operatively the target is -1. There is no error to calculate. The treatment are available only with a grid optical zone of 6.5 and for standard eyes of 43 keratometries. The clinical refraction is very important. If we use cycloplegic as atropine or other one, do not underestimate hyperopia and not overestimate myopia. Donc, in my nomogram, the step 1 is cycloplegic refraction. Step 2 is examination asphericity. You have to enter the eccentricity. Eccentricity is the same thing as asphericity, 0, 0. For the examination data in the examer laser software. And step 3 is to fix the Q value target -1, your goal, for the both eye. The step 4, you can see on the Zernike polynoma, the hyperopic shift. You can estimate it. Because if you compare the C4 after Q value -1 and the C4 before at the examination with Q value 0, you can have the difference between 7.0 to 4.5, and the shift is precisely, very precisely. It's not a clinical expectation. It's a real nomogram theoretical inside the machine. The shift is precisely 2.4 microns of RNS-C4 Zernike polynomas, and it does correspond to approximately -1.84 diopters, 87 diopters. Then it's very precise. And from case to case, we have built the nomogram. But it depends also of the keratometry. It's very important. As before, John Beauvais or Charles Genasia have said to you, there is a variation of ablation depth depends on keratometry. A very good, very important parameters. Then you have to use for 43 diopters of keratometries. The target sphere is -1.87 to conserve the metropia. And if you have some astigmatism, you have to consider the spherical equivalent as to be used in the nomograms. For instance, -3 and -2 astigmatism, you have to consider -4 instead of -3 in the nomogram, and in the case 2, +2.5 and 5 degrees plus 1.5, you have to consider the spherical equivalent 3.25 instead of 2.5. I give you some precise example after. It depends of the keratometries. With the keratometry of 40 diopters, the target sphere is only -1.4 instead of -1.87. And if the keratometry increase to 46 diopters, the target sphere increase to -2.42. Then we have built complete nomogram. Theoretical nomogram depends of the keratometries and the amount of ametropia. In case of astigmatis, you have to consider the equivalent, spherical equivalent in this slide. On this slide. Case 1. If you consider a female 52 years old, hyperopic, the topographic pre-post-op results. The right eye is cycloplegic, 2.75 diopters. Spherical equivalent is 2 diopters. The target sphere with keratometry 42 is minus 2.08. Now we are treating, in this case we treat plus 4.25. The second eye is the left eye, the same thing, it's plus 1.75 diopters. The nomogram shows with 42 diopters. The target sphere is approximately minus 2.07. And you have to treat 3 plus 3.75 diopters in sphere. The results are very, very good. And the binocular visual acuity is 20/20 Jaeger 2 in this case. The second case is a male of 47 years old, an ametropic patient, a very businessman. It's approximately the spherical equivalent is plano. On this slide we can, with for 42 diopters, we have obtained a spherical target minus 2. Then we treat plus 2.75, 25 diopters. The second eye is the same thing, and the result is so very, very good. And this case is a myopic eye. It's very important because we get very, very good results in myopic eyes. It was a little bit surprising, but the results are very, very good. And we can see on this slide an highest keratometry, like a little island on the topographic postoperative view. Then, if you have a myopic eye, the right eye, minus 3.25, we can see the real treatment is less. It's only minus 1.5 in using the nomogram. Then, if you have to treat an hyperopic patient, you have to overcorrect it with Q value minus 1. And if you treat a myopic eyes, you have to treat less. It's a very tissue saving. It's very important. The same thing for the second eye, and good clinical results. And another case very interesting because there is some ametropia, a good astigmatism on the right eyes with a little amblyopia, and ametropic on the second eye, and we obtain a good topographic results with this very difficult case. Then the target sphere is plus 4 and 13 degrees minus 4. The spherical equivalent is plus 2. And the nomogram gives us theoretical sphere plus 4.08, and we treat with FCAT treatment plus 0.25 diopters. So we obtain good results, like we can see on this slide. But if you want to use this nomogram, there is not complete value if you have 1.25 or another diopters. You can use a formula because we have translated this nomogram on the on the curve, and we realize there is some parallelism between the different curves. It depends only on the keratometry. Then there is a formula. The target sphere is in a relationship with the ametropia by these polynomials. Then we can extract different formula depends on keratometry. And for example, if you enter +1 diopters, you can calculate it precisely, and we can verify that you calculate target sphere minus 2.07. That's the same we can obtain on this slide. Then this nomogram is right because it's not a clinical nomogram, it's a theoretical nomogram extract from the Zernike polynoma of the machine. Thank you very much and have a good surgery.